Good morning, good afternoon, everyone. So it's a real pleasure to be here with you for this another webinar from the PCR Webinars family. And today we're going to discuss the issue of the female gender when it comes to TAVI. So to join me with for that discussion today, I have the great privilege to share the webinar with friends of mine that you all know. So we have Julia Mascher-Bauer. So hi, Julia.
Hi.
Sabine Bleitzifer. Hi, Sabine.
Hello.
And last but not least, and you all know him, Philippe Généreux. So hi, Philippe.
Bonjour.
Thank you for being here. So just one a general rule, because you are now more than familiar with these webinars. It has to be interactive, because all these webinars are dedicated to you guys connecting online. So thank you, first of all, for being here. And what is really important is that you be part of the discussion. It's just a discussion among ourselves, you and us, just to better understand the topic of the female gender when they're undergo TAVI. So come up with any kind of questions, comments, thoughts that you may have, and we will try to address them during that webinar. So we have you have the option to formulate your comments online, and we will discuss them. So what are the learning objectives today? So the first thing is to try to understand the gender differences in terms of diagnostic and treatment of severe aortic stenosis. Is there a difference between male and female? The second one is to discuss the latest evidence, because 2024 was quite dense in terms of learnings for the topic of the gender differences with AS. And at last, we will try to capture the differences and the various treatment options, whether it be surgical, transcatheter, and the inherent challenges when it comes to treating this under-diagnosed, under-treated population of women. So I think we can kick off that webinar, Julia, with your first lecture, trying to drive us through what we know in terms of AS and female gender. So thank you, Julia.
Thank you, Didier, for the nice introduction. Please, my slides, please. Yeah. So I would like to start off with the facts that we know about sex-related differences in the treatment of aortic stenosis, and we don't know very much. There are few data that have been published, and that showed basically that women diagnosed with aortic stenosis are less likely to receive aortic valve replacement in the existing literature. Potential reasons for this may be more comorbidities in women that present, patient preference, but maybe also awareness of doctors to refer women for AVR. Next. That's why the ESC Valvular Heart Disease 2 survey has been carried out and recently been published. It assessed, on the one side, the prevalence of valvular heart disease in Europe and the management. And as you can see from these two graphs, aortic stenosis patients in orange formed the largest group among women on the left and men on the right. Next. Next slide. So the management of aortic stenosis in this survey. Next. About 1,000 patients underwent intervention. Next. And women were significantly older, less often received concomitant procedures. TAVI was performed more often in women. But in-hospital mortality was also doubled in women. And although women overall received more TAVI procedures, when baselines were adjusted for the Euroscore, the difference regarding the treatment of aortic stenosis between men and women was not different. And among patients that had a concordant indication for an intervention. Aortic stenosis patients, again, there was no treatment difference between men and women who presented with aortic stenosis. So obviously in Europe, we could not find such differences that were reported before regarding the indications and the type of treatment. Reasons to withhold interventions in women were more often age, patient refusal, and improvement of symptoms after therapy. So there have been in the past there have been a few studies that TAVI benefits female patients, and we know from the Partner 3 trial that overall patients benefited from intervention in comparison to SAVR, and this benefit was more pronounced in female patients. And the SDS TVT registry also showed that women that received a TAVI had a lower mortality rate as compared to men. Next. Based on these previous data, the RIA trial was rolled out, and the results were recently presented at the ESC by Hélène and received a large echo by the media. Next. The RIA trial was a European trial and a multinational multi-center trial that included 443 patients in 48 sites. The next slide shows you the RIA trial design. Women with symptomatic severe aortic stenosis who were eligible to undergo either TAVI or aortic valve surgery were randomized 1-to-1, and the 221 TAVI patients, 222 surgical patients were then finally eligible for analysis. And here are the baseline characteristics. Patients were young, 73 years on average, and had a low risk for intervention. The SDS score was only 2.1, the Euro score 1.7% on average. And patients were fairly symptomatic, with more than 1/3 in neurofunctional class 3 or 4. With regards to aortic stenosis severity, they suffered severe aortic stenosis and had small aortic annuli that were on average only 400 millimeters square. Next. Which resulted in small implanted devices. So in the surgical group, more than 80% of patients received valves with sizes between 19 and 23 millimeters. In the TAVI group, 2/3 received 20 or 23 millimeter valves. Regarding procedural complications, these were very low, with only 0.5% and similar in both groups. The primary endpoint is shown in this graph. The primary endpoint was defined as death, stroke, and rehospitalization, and was reduced by 50% in the TAVI group. And this was driven by a significant reduction of rehospitalizations among patients who underwent TAVI, while there was no difference in death or stroke rate between TAVI and surgery. With regards to secondary endpoints at 1 year, the rate of new pacemakers was low, below 9% in the TAVI group and below even 3% in the surgical group, while new onset atrial fibrillation at 1 year was almost 30% in the surgical group, but only 3% in the TAVI group. Next. Next. Very important secondary endpoint to my mind is the rate of patients that could be discharged home, which was 90% among TAVI patients, but only 50% in the surgical group, and also the median index hospitalization was only 4 days in the TAVI cohort compared to 9 days in the surgical group. Next. So these results were very promising, and but the patient numbers still limited. And to build up this evidence more, the RIA data were then combined with the data of Partner 3 and presented by DDA just a few weeks ago on the TCT conference in Washington. Next slide. And as you can see here, that these data were easily mergeable because the primary endpoint for RIA and Partner 3 were similar. In the Partner 3 trial, only 30% of patients were females, but the baseline characteristics were very similar. Next slide. Age was in these combined cohorts, again, young, 73. The STS score and the Euro scores were very low. And among these now 376 TAVI and 336 surgical patients, the CT area, annular area was again around 400 millimeters square. Next slide. And also in this larger cohort, the rate of small surgical and TAVI prosthesis was high, comparable to the RIA analysis. Next slide. The endpoint was again reached by only 8% of TAVI patients, but 16.8% of surgical patients. The endpoint was all-cause death, stroke, or rehospitalization, and again driven by rehospitalization, which was significantly more often documented in the surgical group. Next slide, please. Next slide. While all-cause death and all-cause stroke were not different between groups. With regards to other outcomes, new atrial fibrillation at 1 year on the right-hand side was only 4% in TAVI patients, but 23% in surgical patients. Pacemakers were very low in both groups. Next slide. So with this, I would like to conclude. Women with aortic stenosis are older at presentation, suffer more comorbidities than men. Based on the RIA trial results, which showed significantly fewer rehospitalizations at 1 year, treatment with a balloon expandable bioprosthesis could be considered the preferred therapy in women. The combined analysis of RIA and Partner 3 allowed the largest all-female analysis in severe symptomatic AS and confirmed the RIA trial results. But profound considerations regarding lifetime management are of high importance for the management of both female and male patients. Thank you.
Thank you very much, Julia. So I have to say that this was a very insightful presentation, and thank you for sharing the knowledge that we have today. Trying to understand what is the impact of AS in women, and what is something that is striking is the under-diagnosis and under-treatment. So, because if you nicely show that the incidence of AS is exactly the same in male and female, but at the end of the day, they get less diagnosis. What do you think is the main reason for that? What could be the main reason for not coming to getting an echo and then after that surgery?
Probably women show up less frequently, but the mode of stenosis is different. As women have smaller annuli and smaller aortic valves, they have less calcification because if you have a smaller valve, less calcium fits on your small valve, which is already respected in the cutoffs for CT calcium load that indicates severe aortic stenosis. But still, there is probably a gap, and we may underestimate still severe aortic stenosis in women as compared to men.
Thank you. Philippe, you nicely brought to us the early TAVR data. And did you observe in the cohort of patients that you had, the female cohort of patients, different metrics in terms of hemodynamics? Was there a difference in terms of degree of AS, the gradients, the LVUF, when you compared male to female?
Yeah, that's a very good question. So in the early TAVR trial, we had 30% of women. So again, underrepresented to your point earlier. Second, there was no difference for the early benefit in the subgroup analysis that we did. So early intervention was superior to clinical surveillance in both in men and female. That said, your point is very well taken. Smaller valve with women, also thicker ventricle, so the smaller cavity, more LVH compared to their body size. So I'll point it out to a little bit more challenging patient, smaller cavity, hyperdynamic LV, et cetera, et cetera. So obviously we're going to run a lot of sub-analysis on those topics, but it's very fascinating to see that those are very consistent to trial, those findings. Less representation, smaller anatomy, and thicker ventricle, smaller ventricle, and more challenging to treat early on.
Thank you very much, Philippe. Julia, I would like to come back to you because you nicely showed within your slides that the outcomes when we compare TAVI to surgery in female are slightly different. And what could be the main explanation for less rehospitalization? Do you think that there is a role of the AF and the bleeding complications, or do you have other explanations for that?
Yeah, that's a very good question. And we just recently discussed this with the surgical colleagues. Actually, I'm not sure. Probably a patient at the short period of time that patients are in the hospital when they receive a TAVR leads to a very continuous treatment, medical treatment with drugs. And as soon as you have a large surgery, everything is taken off. You're going to intensive care unit, and then you recover, and it takes much longer. And afterwards, you have to put everything on again. And it may be, to my opinion, that it is very difficult to establish a steady state after open heart surgery in a very short period of time, because as we have seen, this is only 9 days that patients stayed in the hospital, but this is still short to establish everything stable again. And probably this is the reason why patients come back more frequently, because it's just that the steady state has not been reached yet.
Thank you.
It's my one opinion, one possible. Yeah.
It's a very interesting opinion. And maybe I can turn to you, Sabine, as a surgeon. So we understand that there are challenges in taking care of the female after a surgical aortic valve replacement. If we go a step back, do you think that during the surgery you have technical difficulties that you could bring to us? Because Philippe said small annuli, Julia said more fibrosis, the LV is more hypertrophic, small cavity. We understand that the management after surgery is a little bit difficult. Per procedure, is it different when you compare female to male for you as a surgeon?
Yes, so obviously the main factor for different outcomes seems to be the smaller size of female anatomies, the smaller root, which might be more difficult to manipulate surgically, to take out the old valve, to put in a new valve, to close the aorta. All those things might be more technically demanding. So that's the general opinion about that. I personally think, but there are also some things that are easier in female patients. For example, the thoracic cave is much smaller, so the distance from the thoracic wall to the operative site, to the aortic valve, is much shorter. So indeed, I sometimes feel female anatomies might even be very nice to operate on. So, but of course, there is no other explanation that the small aortic root seems to pose an additional risk.
So thank you very much. So I think it was a very first part of the discussion, trying to understand the inherent challenges about diagnosing female AS in female patients, bringing them to surgery that remains the gold standard. And we properly now understand the technical challenges of surgery. And based on the REA and P3 data, we may bring the hypothesis that TAVI could be a preferred option, because if they don't get surgery, maybe something that is more simple to carry out could be the preferred option. But there could be also inherent challenges of TAVI in female patients. We said small anatomy, maybe they are more bicuspid. So I would like to invite Philip. Philip, if you could drive us, and we're going to discuss based on the case. The first case is going to be a TAVI in a small anatomy. Thank you, Philip.
Thank you, Didier, and thanks for PCR for the kind invitation. I will present a common case, a real-life case of a small annulus in a female, case that we did a couple of weeks ago, and just walk you through this routine cases. Here's my disclosure. So first, she's a 75 years old female, low risk for a surgical AVR and also TAVR. She's hypertensive. She presented to us with a mean grade of 75, so critical aortic stenosis with a New York Heart Association 2 dyspnea. As you can see here, she has a very great anatomy, so the vessels are straight, no tortuosity, no excess of calcium. She has low bifurcation, which is ideal. You can see the mean diameter of the vessel around 8 millimeter, so somehow great anatomy. So the STJ, first findings, the STJ is rather small, so 23 millimeter STJ with see mild to moderate calcification. I always like to look at the STJ as the gatekeeper of the valve size. So and you can see there's also significant severe calcification at the annulus and leaflet level. As you can see here, you can see the sinuses. So the left sinuses is 25.8, the right is 24.8, and the 27 for the non-con, which is an average of 25. So rather small sinuses, and this will become important if we talk about different type of prosthesis, either balloon expandable or self-expandable. And you can see here in the movie a lot of calcium, bulky calcification on the tip of the leaflet, especially the left leaflet, which would be important in terms of coronary occlusion risk, and also the tip of the right. So the distribution of calcium is very important on this woman. And you can look at the annulus sizing. It's a truly small annulus. It's under 300 millimeter square. The perimeter is 63.4. So clearly into the area of either Sapien 320 or the area, if you want an Evolute Pro, I would say 26. Too large for 23, I believe, but clearly a very small annulus. One other characteristic is a low left main, so 11 millimeter, especially in relation to the small sinuses and the very bulky tip of the leaflet at the left cusp. The RCA was pretty high at 19. So the concern on this patient was small STJ 23, small sinuses 25, annulus in a range of 20 Sapien or Evolute Pro 26. So that led the decision to us to prefer to do a TAVR first. The woman preferred TAVR, and we can talk if we could have done surgery. Right femoral access with coronary protection, because we're very uncertain with the behavior of this left cusp. So first, we like to do a balloon valvuloplasty. I personally don't do valvuloplasty a lot. This is probably 5 2% of my practice. And then in this case, because of the bulky calcification, we elect to do a balloon valvuloplasty, and we can see that the valve expand pretty good. We also elect to protect the coronary because of the leaflet, and you can see the S320 valve was implanted, LV pacing with a TAVI wire. You can see on the top of the screen the chunk of calcium that really get displaced just at the base, actually, of the left main with no occlusion. We did an angiogram after just to confirm the patency of the coronary, very normal coronaries. And you can see here the displacement of this bulky leaflet, but with patent left main and plenty of room. The sinus were 25, so the 20 fit well. Very great gradient, went from mean gradient of 75 to 4. That was directly intra-up with a PVL, with a trace PVL. So somehow great result. So I'm going to stop here, and we can discuss the case.
So thank you very much for this nice and quite unusual case. So it's technically challenging. So we can nicely discuss a couple of challenges inherent to the small anatomies of women. 40% of the women have a small anatomy. So it's 40% of the patients have a small anatomy, and 90% of these small anatomy patients are women. So it's a lot of, it's a quite frequent finding. So let me start maybe, Philippe, by trying to understand what is your own experience, because using a 20mm S3 is not that common in Europe. So what can you tell us about that device in terms of hemodynamics and what you get, what you observed in your practice?
Absolutely. I would say it's not common for me neither. So we have an algorithm, and obviously we like to put a large valve as possible, if safe, as safe as possible. But I would say that some patients are small, have a small BSA, and it will be the appropriate valve. So in this particular patient, obviously, the sinus was very small. The debate was between a self-expandable valve and as balloon expandable 20. Unfortunately, the leaflet, as the sinuses were too small to accommodate for self-expandable valve, first concept. Second characteristic, the left main was very low. So I was very afraid to push this left main, to occlude this left main with the leaflet occluding. So in the algorithm, obviously, that was the only option left. Obviously, we could have gone to the surgery we can discuss, but a small annulus with a root enlargement in a female, it's increased a lot of the complexity of the surgery. So I would say in our practice, I use probably 1% or 2% of S320, very rare. In men, almost inexistent. In women, occasionally. And it's all about the anatomy. There's a lot of patients, and I think it's not discussed enough, but a lot of women, as a matter of fact, have anatomy that are not good candidate for self-expandable because everything is small. So the sinus are small too. So I think you always have to go back to the anatomy. Can I put safely a self-expandable valve in the sinuses? In the SMART trial, for example, there's a significant amount of patients that were not included in the trial because the anatomy was not suitable for one valve or the other. So I think that's to assume that one valve will fit all female is wrong. I think the key is to look objectively what is the best option for a given anatomy. This anatomy is special because obviously the sinuses were not large enough. If the sinus were large enough, I would have chosen most likely a self-expandable valve. If the left main was a little higher, I would have been comfortable with a self-expandable valve as well. So in terms of hemodynamic, this hemodynamic often come back at 30 days with gradient of 12, 15, not rare to see 20, to be quite honest. But patient always happy. They have great quality of life. They are still thankful with no complications. So it still remains to be determined what this number at 30 days or 1 year means. What is a gradient mean graph 20 means for 5 years, for 10 years follow-up? And also, what does it mean to have either a balloon expandable or a self-expandable as far as retreatment in 10 years down the line or 5 years? So I think that those considerations are important. So far, so good. At 2-3 years, those patients do great. And the retreatment, obviously the retreatment of those valves will potentially be with a self-expandable or maybe another 20, but potentially is self-expandable. Especially if we have tools, so the shortcut, we can cut the leaflet and modify the leaflet. So that's my 2-minute summary.
Thank you. Thank you, Philippe. So having heard Philippe, Julia, if we consider self-expanding platform, because in Europe we have the ability to use various self-expanding platforms, and we had, for instance, apart from the SMART trial that compared the Evolute FX to the SAPIEN 3, SAPIEN 3 Ultra, there was, for instance, the TAVI small registry showing that with self-expanding platforms, you get better hemodynamics. So do you have, if it was your patient, would you have it utilized and you aim at using a self-expanding platform? Do you have other options that you could suggest, or would you stick to a 20 S3?
Well, as Philippe pointed out, the lower left main is a challenge here, and in such a situation, I would only, if you want to take a self-expanding platform, then probably only the accurate would be nice here in this situation, and a deep implant. Apart from such considerations, I always look at age, lifetime management, what's next, what's the situation of the patient, what's the general situation, is she frail or is she very fit, do we expect a second implant? And this is the most important aspect to me. And if we consider a second implant, you can only use a balloon expandable valve. In this situation, probably an accurate valve, probably. But better, safer at present, probably the balloon expandable.
So I like the idea of thinking about the future, but let's discuss that a little bit later on. I would like to turn to Sabine now for 2 points. The first one, potentially this could be if it was this lady was a surgical candidate, what would have been the options? Because here we have the combination of a small anatomy, a risk of coronary obstruction. What would you do if it was a surgical case? And the second question that I have for you is, could you elaborate on the potential impact of severe patient prosthesis mismatch in younger patients, in female? So surgical aspects, and then the severe patient prosthesis mismatch impact.
Yes, thank you for these great questions. May I ask again, I don't remember, what was the size of the annulus in this patient?
19.5.
19.5. So if we would discuss about surgery in this patient, it is very clear only a 19 millimeter valve would fit in. That means we always should aim to avoid 19 millimeter valves, and so there would be surgical options with enlarging the annulus. But this requires a good pre-procedure planning of the procedure. And that's the challenge with surgeons, because it is still not well understood that we need to plan our procedures also. Because if you are not aware of this issue, that there is a small annulus and there is the need of doing something else, and you would start maybe with a very small axillary access, maybe it wouldn't work technically. So we have to learn to plan our procedures, and then this patient could have a really great result with maybe a 23 millimeter valve, with also a good option for lifetime management with another procedure if needed. So this would be my surgical discussion about that. And the coronary obstruction is not an issue with surgery, because we cut out the calcium. And next, the impact of mismatch. That's, of course, a topic that is discussed very controversially. Depending on how it is measured, how it is anticipated, mismatch does have impact on long-term outcomes in several group of patients, and especially in younger patients. So my interpretation of this is, so the younger and healthier a patient is, the more such a factor or parameter like patient prosthesis mismatch does play a role. In older, very sick, comorbid patients, this is only one factor amongst several others and does not come out as an independent parameter of outcomes. So the younger the patient is and more active a patient is, I believe the more important it is to also reflect patient prosthesis mismatch as one factor for procedure planning.
Thank you very much. Very clear. Philippe, so last comment from your side. So this is what you did for your patient with a superb outcome. If we think about the redo procedure, what would be your combination, anticipated combination? Short in short, tall in short?
Mm-hmm. Yeah, so I think for this patient, hopefully she's not going to come back soon. If she come back, let's say in 5 years, I think the good news with this picture is you see that the frame is is below the coronary level, which is very reassuring. Which yes, we could do another 20 to 20. Will I do that? I'm not sure. Or can I do a self-expandable valve? Most likely a self-expandable valve. Okay. And if we need a third procedure, this is where the leaflet splitting will be helpful to ensure that now we can put a short valve. And that, those patients are very challenging. I mean, I think we deal with a substrate that are very, not infrequent, not frequent, but not infrequent. And this is a case-by-case discussion. So I think this is what I would most likely do an evolute after that. And if she need after that, we'll use a shortcut procedure with a short valve inside.
So the future is really promising. Thank you for that. So it's very, I like to discuss with you guys because the more I talk with you, the more I understand what are the challenges of women. And clearly we are saying that women come later to surgery at a older age. So potentially we could intervene earlier in younger patients. We understand the small anatomy and the challenges, but if we are tackling younger patients, we're going to meet more bicuspid patients. So it's going to be the topic of the second case. Sabine is going to drive us through a bicuspid case to have another discussion. You guys connected online, remember, feel free to come up with any kind of comments and we will address your questions. But let's now move to the topic of slightly more challenging cases, another type of challenge with the bicuspid anatomy. So Sabine, thank you for sharing your case to stimulate the discussion.
Thank you. So the patient I would like to introduce you was or is a 74-year-old female patient. She was treated just last month in our center. She came and complained about dyspnea on exertion, and she experienced this since 2 or 3 months. She had recurrent syncopes, but that was known for many years, and she now suffers from increasing exhaustion. An aortic stenosis was known in her history. Her overall risk profile was very low. She had no severe comorbidities, just a hip joint replacement in 2016, but with a great result and no impairment in her activity. And accordingly, her Euroscore 2 was low, 1.68%. So this is a real low-risk patient at 74 years. The echo was done, and what we saw was a mean gradient of 37 millimeters mercury, aortic valve area 0.8. You can see just a minimal regurgitation and thickened leaflets and reduced leaflet mobility and reduced opening. We did a baseline CT in this patient, and what we saw there was that this is a patient with bicuspid valve type 1 with fusion of the right and left coronary leaflet. She had quite some amount of calcium in her aortic valve. The raphe between the right and left leaflet was calcified at the base, but not at the edge of the leaflets. But still, we know there might also be some fibrosis. Because you don't see calcium here does not mean that the fusion is not complete in these leaflets. What we also see is that there is no LVOT calcium. And when it is now to measure this valve, it is clear, you know, from the semi-automated programs, they also have an option to put only 2 dots in a bicuspid valve. But this bears quite high risk of overestimating the annulus if you don't get the correct plane of the aortic valve. So it is always better to set 3 dots. And in this valve, I think this was very reasonable, because you still could identify the 3 leaflets and the 3 sinuses, although the dots are now a little bit asymmetric. And the size we measured was 477 square millimeters, so much larger than Philippe's patient we saw. And this is quite common in bicuspid aortic valves, that they have larger sizes. Looking at the height of the coronaries, they were very high, 17 on the left side, 20 millimeters on the right coronary, and also the sinus widths were large, with more than 30 millimeters. In bicuspid valves, it is always important to assess also the ascending aorta, if there is any concomitant aortopathy. In this patient, we didn't see an aneurysm. The ascending aorta was 39 by 37. The peripheral arteries were small, 5.5 millimeters, but without any calcium. So what did we discuss with this patient? We had a patient, 74 years, low risk, female patient, and she had a strong wish for TAVI. Usually, according to the guidelines, also in patients below the age of 75 and with a bicuspid anatomy, we would, in general, recommend more to go for the surgical procedure. If this patient would undergo surgery, we would do a minimal invasive aortic valve replacement through an axillary access. Usually that means no bone splitting would be necessary. That's what we told the patient, and that this would be really a low-risk surgery. When we look to the guidelines, this would also be the recommendation to put in a surgical valve in a patient below 75 at low risk. But this patient had a strong wish for TAVI. So when we look at the anatomy, although it is a bicuspid anatomy, I would say this is quite a TAVI-friendly anatomy. There is no excessive calcification, no really crazy asymmetry of the calcium, no calcified raphe, no LVOT calcium, and also the peripheral axis is good, and there was no aortopathy. So all over, I would say still, although it is a bicuspid anatomy, this is a TAVI-friendly anatomy. We told the patient that she might have a higher risk for pacemaker or PVL if she receives a TAVI, and she did understand that and still opted for a TAVI procedure. Concerning lifetime management, we also told her that there is more knowns if we would do a surgery first and as a second procedure, the valve-in-valve. So, first of all, you can see here the aortic root shot. It is very important to get the correct plane during the implantation, which might be more challenging in the bicuspid anatomies to find the correct plane for the implantation. And also for positioning of the valve, it is very important to be clear if you are in the correct plane and that the view is not off. We decided to implant a 26 millimeter S3 prosthesis because she is so young and because we wanted to leave the coronaries for later potential procedures, and also because we would think in this anatomy the risk for a PVL maybe would be less with a balloon expandable valve. And here is the implantation. And still, although the raphe is not calcified, you can see some shift of the prosthesis towards the non-coronary cusp, because the raphe is the raphe hinders the valve to expand fully there. The invasive gradient we measured was 1 millimeters mercury, and you see this was a really straightforward procedure, only 5 minutes radiation time. So the final result, you can see here, just a very minimal paravalvular leaflet. The patient was discharged on postoperative day 6, but mainly because day 4 and 5 were Saturday and Sunday. She was very fit very soon. She had a new bundle branch block, and she was put on the audiometer because she had one episode of atrial fibrillation, which could not be, was not. We couldn't find a second episode even on the audiometer. She was able to have 95 watts. And on the discharge echo, we found a gradient of 12 millimeter mercury. So I think that's very reasonable, although on the table she had only 1 millimeters mercury. This is my patient. I'm happy to discuss with you if you would have done something else, or if you would have forced her to surgery or whatever.
Well, thank you very much, Sabine, for once again a very nice case, contemporary patient, and all the challenges that we can encounter in daily practice. So bicuspid is definitely a topic for which we are still learning. So the first question for you, because you have the advantage of combining the surgical skills, the transcatheter skills, what is a suitable patient, or even more important, which type of patient you wouldn't send for TAVI? You would always consider a surgery. If you had an advice for the audience, which type of patient or anatomy would you systematically send for surgery?
Yes, of course. So we are talking now about low-risk patients, because if we are talking about very high-risk patients, we of course would accept also less friendly anatomies for TAVI. When we see low-risk patients with bicuspid anatomy, if the raphe is heavily calcified, if there is LVOT calcium, if there is very asymmetric calcium, and also sometimes the coronary takeoffs can be very weird and anomalous in bicuspid anatomies, and also if there is aortopathy. So these would be patients where I would strongly recommend for surgery. And in very extreme cases, we would even not accept a patient for TAVI if the anatomy is really not good, if we don't expect a good result, and it's a low-risk surgical patient.
So thank you. So Julia, Sabine nicely illustrated the worst anatomies, and when we have a combination of excess of calcium, a calcified raphe, but she also mentioned the aortopathy. Is it something that you integrate in your algorithm decision-making process? And is there a cutoff for which you would still discuss either the type of device if you go for TAVI, or either to consider surgery again? So aortopathy and any kind of cutoff that you have in mind.
You have all the good questions for me today. Well, the cutoff, as we both know, is difficult. There are of course, the guideline recommended cutoffs that we all know, which are lower in bicuspid valves than in tricuspid valves. But we see very many, well, not very many, but we see quite a few bicuspid patients who have aortopathy and who have too high surgical risk, and we treat them with TAVI. And what we should do now next would be to monitor their aortas to see what really happens to these, because I think we don't know. There are some studies or ongoing trials out that evaluate or follow up these aortas, but we don't know to what extent and what are the characteristics that that you should look out for to decide whether you have to do surgery on these aortas or not. In young patients that reach the cutoffs, I would simply send for surgery, and in older patients, we go for TAVI, and we accept the orthopathy as it is. Yeah,
Thank
that's
you.
the take we have in our center at present.
But I like the idea of, I think we need that. That's the literature or knowledge gap that is still present. What is the fate of the orthopathy? And I like the idea of either retrospective registries, accumulating, gathering a lot of patients and trying to follow these patients with serial CT scan assessment, or even better, a prospective registry. We do the procedure, we do TAVI in patients who are not suitable candidates for surgery, and then we follow these patients to see what is the fate of the aorta. Is it still continuing to enlarge, or is it getting back to normal, or is it stable? That is going to be very important in the future. So thank you for bringing this issue. Philippe, bicuspid is a very, very frequent finding in not daily practice, but every week, every month, you treat a bicuspid patients. And we are all struggling with sizing. Sizing is something that is central. Do you have something that you would propose for the audience? Is it a systematic all for the annulus dimension, and then you use the annulus, or do you have another approach, something that is more integrative? What do you do at your institution?
Yeah, so I think you publish those criteria actually with the Bavar registry, obviously, and I believe they're very insightful. In this patient, it was clearly a 26 valve, and like Sabine mentioned, it was a very friendly bicuspid. We will expect some sort of movement of the raphe because it's not super calcified. The shape of the annulus and the tip of the leaflet was probably conic, and you probably can fit a 26, and there's not too much movement on the opposite side, which can create problem. If this patient had a lot of very calcified raphe on the right and the left fusion, and you don't expect any movement, this is where you can undersize the valve, especially if there's hostile feature on the other side on a non-coronary cusp, if there's LVOT, calcium, annulus. So you need to kind of imagine the behavior of the valve, because sometimes what's happening, the raphe will not move and the valve shift on the very eccentric fashion and will rupture the other side. So that's why we if you have a conic shape, and this is where you can undersize the valve with a 23. The 23 plus 1 or 2 cc will have words, probably, but because the raphe was not super calcified, and I think the 26 was the perfect choice. Those patients do well also with self-expandable valve, probably a soft landing, and you can post-dilate them as well, maybe a little bit more leak. So I think for me, you really need to assess, like Sabine did, what is a calcium score, what is the distribution of calcium. If the raphe is expected not to move, this is where you enter a dangerous territory where maybe surgery is the best option. Or if the patient is not a surgical candidate, you need to undersize the valve. And this is where your different classification of the whether you have a triangle like trapezoid, like where the annulus is large, but you have a tapering at the tip of the leaflet. I think the valve will incur on those. If the raphe is the pseudoannulus at the tip of the leaflet level is less, you will safely perform an S323 plus 1 or just nominal. So I think you need to integrate the neo annulus and also the calcium distribution on what side of the leaflet. I would say that this root at 40, if the patient was 65 or 70 with a root of 40, with this type of bicuspid, maybe a root replacement was being proposed in some aggressive center. And I think our surgeon, not that I'm a surgeon, but when I listen to them, what they say when they open the chest, they can appreciate the texture of the aorta, and then they can know if there's a collagen deficiency, and or this aorta will continue to grow. So I think this is something we don't have, but there's technology that are coming to thoroughly assess the histopathology virtually by imaging, and to say, well, this is not just the jet of the aorta giving an eccentric dilation, is a tissue collagen deficiency, which is going to continue to grow. Into your point, I think we need to refine our bicuspid, because there's some people at 40 that need a root replacement, probably that have an histopathology that will continue to grow. And then we don't make a service by doing a balloon expandable at 70. So I think much more to come, but I think the histopathology of the root will be key, and maybe we're going to refine the cutoff for root replacement, actually. But yeah, it's for the future.
Thank you. And Sabine, we have still a couple of minutes left. There is one item that I always like to discuss is bicuspid are more challenging. Sometimes you have most of the time you have bulky calcification. So you think about the stroke, the risk of stroke. Do you use cerebral protection devices in this particular setup of patient, or are you still performing TAVI without any protection, and are you happy with that? What is your routine practice for bicuspid and cerebral protection devices?
So we used to use much more cerebral protection devices, but as there is still no really convincing data, during this year we almost didn't use any cerebral protection, I think, because and we don't see an increase in stroke rate. So I think there is at now not enough data to justify that. So during the past couple of years, we did use it in patients at more higher risk for stroke, as we rated it. So, and that was highly calcified bicuspid, valve-in-valve procedures, or patients with a stroke in their history. And if I may, I would like to bring up another point. It was mentioned that in the bicuspid, there is a lack of data also, and there is the upcoming Navigate trial. That's something we should have in mind. And there will be a randomized part, almost 1,000 patients, I think, surgery versus TAVI, in all bicuspid anatomies, and registries in patients who cannot undergo both procedures. And maybe this will also be an option to have a view on the fate of the orthopathy.
A very important upcoming trial, effectively. So that was a very exciting, inspiring, insightful discussion, guys. So thank you for bringing up what you know about TAVI in female patient. So I learned a couple of points, a lot of points discussing with you. The first one is that clearly there is an underdiagnosis, undertreatment of female when they have a severe aortic stenosis. So we need to work on that. A better awareness, raising awareness about the impact of AS and the symptoms of AS in female patients that might be different as compared to male. Bring them to an echo, because they don't get the echo enough. So we need all as a community to work on that, to make sure that we properly diagnose AS in the female population. I also learned that potentially TAVI could be an option, because they could get TAVI, and we've seen through even these very challenging cases that we can achieve exceptional outcomes, procedural outcomes and clinical outcomes for our patients. So TAVI potentially should be discussed and could be one of the preferred options for the female population. And we had the chance to discuss the challenges inherent to the small anatomies, very predominant in the female population, and the bicuspid anatomy also prevalent in younger population. So I would like to thank the three of you for helping me understanding a little bit more about the female condition. I hope that you guys connected online enjoyed the webinar. It's going to be available on replay on demand, so feel free to reconnect and to go through the webinar again. So thank you, Sabine. Thank you, Julia. Thank you, Philippe. Thank you all for being connected, and hope to see you soon. Bye-bye.
Bye-bye. Thank you.
Thank you so much.